when I talk about steroid receptors, I've been talking mostly about estrogen receptors because that's the approved agent where the experience is. I did show one slide from Farrokh Dadashti at Washington University in St. Louis, who's really one of the pioneers in this field, including in steroid receptors. And they have a progesterone receptor that looks like a really interesting functional molecule. But to put that aside for a second, is I think the initial approach is easy. Is we have been relying on tissue sampling to tell whether or not a breast cancer expresses estrogen receptors, right? When we get in widespread metastatic disease, where the choice of therapy is actually pretty important, we can't possibly sample every area. And some of the studies have shown, both by biopsy and imaging, that probably about 25, and in some cases, some selected patients, maybe up to 30 or 40% of the time, there's loss of the ER in that process. And so this is a way of using the system as an adjunct, a complementary approach to tissue sampling, to not only look at the one site you happen to sample, but the entire burden of disease. I'm not saying it takes the place of biopsy, but it's an adjunct. And so you now make a decision on a piece of tissue, which gives you a lot of information, plus an imaging study that shows you the consistency of that target expression. So I think it's a way to really continue to refine our approach to endocrine therapy. And as endocrine therapy gets more complicated in breast cancer, it's even more helpful. And there was a nice publication that I highlighted in the study showing that even when you bring in a CDK4/6 inhibitor, that is an adjunct to endocrine therapy, but it doesn't target the same approach, your predictive value for the response to that combined therapy is still dependent upon the estrogen receptor. We did the same thing in a smaller paper for HDAC, an inhibitor therapy published in the Journal of Nuclear Medicine. I actually took that out of my slides because I didn't have enough time. So I think there's good reason that in this complex landscape of increasing choices for endocrine therapy, increasing choices of what to give in addition to endocrine therapy, the ability to look at the total body burden of disease and assess how it changes over time is actually quite important. Quite a non-invasive, highly specific, very accurate. There was level 1 evidence coming from the Asan Medical Center in Korea suggesting the accuracy of this process. So, so I think that's the landscape. Now, there's a couple of other things you can do here that you can't do with tissue sampling. One of them is getting your drug dosing right. I don't know if that's going to make it into clinical practice, but we were one of the groups when I was in Seattle that discovered fulvestrant was being underdosed drastically. And pretty much all of the folks who are looking at oral SERDs, if you know that landscape, to try to replace fulvestrant, a lot of them are using FES in their phase 1-2 trials to make sure they get the dose right. So that's a drug development process, whether it makes it to the clinic or not, we'll see.